Through maternity care simply tries to ensure that we observe human rights during the time of pregnancy, labor, and delivery. But those rights were derived from certain standards that were drawn by WHO. Those standards are referred to as quality of care services. And what does this mean? Whenever you're doing something, there are guidelines. I think even you media people have guidelines. If you're going to do something, you are told you must do it within these limits. I imagine I'm not a media person, but maybe you are told before you report, first establish facts. Right? And verify your facts. So even WHO guided countries that whenever we are delivering services, there are certain standards we must ensure. And the standards, there are many, they are around 8, but out of those 8, 1, 2, 3, 4, 5, the 5 standards we have found to be direct relationship, have a direct relationship with the human rights we are referring to. Am I clear? For example, standard number 1 requires us that whenever we are managing women, we should ensure that we use evidence to provide any service. Okay? Then, the second standard requires us that we should always use the data when you are going to make a decision. Okay? Standard number 3, it requires us to manage women and communicate with them effectively. Standard number 4 requires us to treat women with respect and dignity. Are you following? Standard number 6 requires us to provide emotional support. I don't know why my slide is cut. That we should be providing emotional support to women and their family. Then the last standard requires us to ensure appropriate physical environment whenever we are managing women. And how to relate these standards to the rights of women? For example, right number 2, I don't know whether you are familiar with the different rights. Mr. Mona, did we have a look at the different rights? You are given the charter. So, for example, right number 1 says, whenever we are managing women, they should be managed when they have freedom from harm and ill treatment. They are able to receive assistance for pain and discomfort. This is the right we are supposed to observe as we are managing women. What standard is required, or what standard was set for us to observe that right? Standard number 5, set for us as ministry, with the guidance from WHO, says that women and newborns should be treated with care and respect. Okay? Then when you come to the second right, that women have the right to information, informed consent, respect for their choices and preferences, and companion of what? Choice. What standard, where did that right, where was it derived from? It was derived from 2 standards. 1, effective communication with women and their families. Then it was also derived from a standard calling for emotional support for women and their family. I don't know whether it is clear. I just want to use those examples to tell you that the rights we are trying to advocate for did not come out of the blue, but we are derived from standards that were set for us by WHO. Okay? The list goes on when you look at equity and dignity, equality from freedom and discrimination. They have a direct relationship with the set what? Standards. Okay? Mr. Next slide. So, having gone through that, why did we do this assessment? The overall goal was to inform the national advocacy agenda there is an overall aim of developing a national agenda to ensure respect for maternity care services. And it was felt ideas were supposed to be derived from the assessment. Specifically, we carried out an analysis where we established the service delivery gaps, challenges, and barriers that are faced by service providers. We analyzed the effects and impacts of COVID. And then finally, we are supposed to facilitate the development of recommendations to advocacy issues to inform the formulation of this agenda. So briefly, these were the 3 objectives. How was the approach? Just switch it off for me. It was very simple. Switch off. Briefly, this was a cross-sectional study. So in essence, what happened, we did a series of things. We went to the respective districts, interfaced with the district administration, went to the health facilities, interviewed the in charge of the facilities. Then we carried out exit interviews. And after doing that, we compiled our data. We had a draft report that we took back to the districts to validate our results. Then when they are confirmed that actually it was a true reflection, we had to go back and came up with a final report. And even when we were doing the validation exercise, we picked some ideas from the different individuals. So, having done that, what did we do? The areas that we assessed, we are looking at things like factors that we are enhancing or preventing provision of respect to maternity care services. We established existing powers of authority in the districts. We also try to establish the most appropriate channels of communication by level. Okay, can you go ahead? So what were the findings? Again, at national level, these were the major things. We looked at the issue, we looked at issues to do with the policies, looked at rights, looked at the coordination, and then regulation. So, these were the different policy documents that were available, and some were taking care of RMC issues. For example, there was the RMC, that is reproductive, maternal, neonatal, child. It is a very long phrase, sharpened plan. There were quality of care adopted guidelines. Those are now the things I was talking about. Then we also looked, we found there was the Uganda Health Sector Development Plan. Then there are also rights charter, like the RMS charter, and then the National Patients Charter. It was there at the National Ministry of Health. Then we found at the Ministry of Health, in regards to this aspect, there are different coordinating bodies. For example, we found that the ministry had a functional national technical working group, which they called the Maternal Child Health Group. And when it came to regulations, for us to be able to implement these things, we found that there is a medical council, there is a nurses and midwifery council, and also allied health professional councils. All those have their different mandates. And I think you were talking about where to get information. In case you are stuck with this, where do you go? There are different bodies that can help us with such things. Now, what were the topmost incidences of respectful care? I don't know whether these, I think they are clear. For instance, it was a range of very many forms of abuse. Okay? And this one summarizes the different findings from each district. Blue represents Iganga, Jinja, Kampala, Kamuli, and Masindi. For example, when you look at the first discrimination based on ethnicity, you find that Masindi stood out was stood out, very prominent. Then when you come to say physical abuse, it was too much where? In Uganda. Then when you come to say this is denying choice of position for delivery, do you appreciate what this means? Denying choice of position of delivery. When we say we denied, we are not observing these women's rights by denying them choice of position of delivery. What does it mean to you? Yes?
Is it to decide where they need to give birth from?
Where they need to give birth from? Anyone else? Yes?
Me, I think it is how the woman decides to give birth.
To give birth. Have you witnessed a woman giving birth? How do they give birth? Do they bend like cows? Do they squat? What do they do? Have you ever witnessed a woman deliver?
Like it is.
Like what?
They lie.
They lie.
They
Uh-huh.
They lie on their back. They hold their legs up. You understand them?
Claps.
And open up.
And open up.
Yes.
Those are the ones you've seen. Have you seen a woman giving birth?
No, through cesarean.
Through cesarean. When you are giving birth through cesarean, do they do it from your back or where?
They have an insertion through the spine.
You see? Actually, women can decide to opt very many different positions with what? Some can decide to lie on their backs. Some prefer to squat. Some prefer, there are many positions, but you know most of us here, what we are familiar with is because the only thing we have is a bed. Every woman we ask them to lie on their backs. Who has been to northern Uganda? Most of those women prefer squatting, and that one alone stops them from coming to facilities. Then verbal abuse. This is Masindi was over-dominated. This one, unnecessary separation of mother and her newborn after delivery. Who understand what this means?
They remove the baby from you and maybe take the baby to the nursery or something.
You get what she said? You see, for you, when you look at it, it may sound immaterial, but some people, why is it that they are taking away my work? Because it has social and scientific benefits. Do you know the benefits of keeping the baby with the mother?
Yes. Yes.
Yes.
Yes.
And why are we telling you this? Because as journalists, someone may only complain, or someone may refuse to go to a facility. Why? Because you know when you are there, they just take away your, what are the benefits?
Of keeping the baby with the mother. The baby breastfeed. When growing, mothers, rare ways mothers handle their children.
We mean immediate after delivery. Immediate after delivery.
I think the region is bonding.
The warmth.
The warmth.
The baby feels the warmth of the mother.
Exactly.
And it's talking of bonding.
You see what we recommend. The moment the baby is pulled out, the baby has to be in the mother's chest. And if we don't do that, for us we believe you are abusing or you are not respecting this mother's rights. So one may be wondering, why is that important? There are so many reasons. Over by the way, the first, they are saying warmth. What kills 80% of our newborn babies is low body temperature. The mother's womb keeps the baby warm. But besides that, when you put a baby on the mother's breast, that baby has an instinct to get onto the breast. You know colostrum. Have you heard about colostrum?
Yes.
Yes.
You know that first milk. It is very important for immunity. But again, when the baby suckles, it may